Intriguing presentation. Now, I would like to invite the following eminent speakers to take their seats at the head table. Professor Jayanta Balavardhana, Dr. Ranga Pereira, Dr. Prasadini Karunaratna, and Dr. Densil Gunasekara. I would now like to invite Dr. Ranga Pereira, consultant surgical oncologist and the Dean of the Faculty of Allied Health Sciences of the General Sir John Kothalavala Defence University, to address you on the clinical and surgical aspects of pancreatic cancer.
Thank you and good evening, everyone. And first of all, I would like to thank the President and the Council of Palliative Medicine for me to invite for this speech. So I will start with the basic introduction of what is pancreatic carcinoma and how it managed surgically. First of all, I would like to introduce you that, remind you of the anatomy of the pancreas. The pancreas is situated as a retroperitoneal structure in the kind of a middle part of the abdomen, in the epigastric and the central abdominal region. And it is very closely and densely adhered to the duodenum, especially the second part of the duodenum. And it's basically inseparable from the duodenum without disrupting the blood vessels which is supplied in that area. So it's virtually unable to separate from the duodenum. And it is very closely associated with the portal vein, the superior mesenteric artery, and the inferior vena cava and the aorta. And so when you're removing these structures, it is very careful when you're removing this without damaging the main blood vessels. So anatomically, we divide the pancreas into the head, neck, body, and the tail. And part of the head is what we call the uncinate process. And this is what we call the uncinate process area, and this is the superior mesenteric and the superior mesenteric artery and the vein, and it continues up as the portal vein. So it's sandwiched between the uncinate process and the body. And you can see the common bile duct comes there and goes through the pancreas, combined with the pancreatic duct and opening into the duodenum. And this binding with the pancreas and the duodenum is inseparable. When it comes to pancreatic pathology, the pancreatic carcinoma, most of the pancreatic tumors are arising from the exocrine pancreas, which is secreting the enzymes, which is digestive enzymes. And you all know the pancreas also contains some endocrine glands, especially the insulin and the glucagon. And it's very small amount of these things are there. And as the pathological entities of carcinoma of that part is also less. It's about 5% of pancreatic tumors arising from the endocrine pancreas. So when we are talking about pancreatic carcinoma, it's basically we are discussing about the exocrine pancreatic malignancies. So 70 to 60% of the exocrine pancreatic cancers are localized in the head and neck area. That's very important. And 20 to 25% of the body and tail is there. The remainder involves the whole pancreas. It's very important. And know that the endocrine pancreatic carcinomas are usually coming from the tail end, not in the head to the neck region. So, mostly the head and neck tumors, they present with jaundice because it blocks the bile duct which is coming through the pancreatic head. The common bile duct which is coming through the pancreatic head will be blocked by the tumors arising from the head and neck area. So the patient usually present with features of obstructive jaundice, right? And the body and tail pancreatic, they present with weight loss and the unusual type of epigastric pain, and sometimes they will be treated various times for epigastric pain and dyspeptic symptoms. Sometimes they present with after dissemination of the tumor. Now, epidemiologically, it's the latest statistics that we have on the National Cancer Control Program. There are only 132 cases reported in 2021. It was 2019 data, I think. And the incidence is 0.66 for 100,000 population. And the peak age, this is the age distribution, is about 60 to 64 age group is the peak age. And we don't have actual mortality of Sri Lankan statistics. And if you go to the cancer control program, there are multiple pages saying the common cancers which you have there. Pancreatic cancer is not on those pages because it's not that common. You can see 132 cancers comparatively to about 1,900 breast cancers in the country. So they don't give a good prominence to pancreatic cancer in statistically as well as epidemiologically because it's a rare tumor. If you take the statistics of National Center of Diseases in Statistics in a database in USA, even if you find it, it's very even early stage. The presentation early stage only about 8.5% in the early stage 1 disease, and even that their 5-year survival is about 20%. Even the stage 1 disease, the 5-year survival is about 20%. When it comes to stage 4 disease, that is where the most patients are presenting, the survival is 1.6% 5 years. Very aggressive tumor. So how do they present? Most of them epigastric pain, epigastric mass, obstructive jaundice, back pain, loss of appetite, loss of weight, vomiting, there's gastric outlet obstruction as well as causing nausea and vomiting by the cancer chemotherapeutic drugs. Migrating thrombophlebitis is one of the unusual presentations of pancreatic carcinoma. It's a paraneoplastic feature, and mostly obstructive jaundice is palpable gallbladder. It's the hallmark of pancreatic head tumors. During our medical student days, it is very, very fond of the surgeons when you see an obstructive jaundice patient. If you have the palpable gallbladder, we all are asked to go and see that patient because that's a kind of a good case which can come to the exam. And it's good actually because early pancreatic tumors comes in head and neck region, and early they obstruct the bile duct, so we can treat them properly. That's at least the good thing about it. And sometimes they present with pancreatitis. Sometimes they present with advanced stage with multiple liver mets or any other metastasis, especially the body and the tail pancreatic tumors. By the time they present, it's already spread because the initial presentation is vague and no one would think it's a pancreatic malignancy until it becomes an advanced disease. This is typical obstructive jaundice face, yellowish discoloration of face and the eye. And you can see the famous personality who passed away with pancreatic carcinoma, how deteriorating that is, the loss of appetite for 1 year. 2007, Steve Jobs was like that, and 2008, Steve Jobs was on the second picture. So investigation-wise, if you have these symptoms, some of them are blood tests. We can do pancreatic tumor markers, CA19-9 and CEA. The first line imaging is ultrasound scan abdomen. We might see the pancreas well, but ideal investigation is an MRI. I think Denzil will talk in these areas more than me. As surgical wise, endoscopy and ERCP, endoscopic retrograde cholecystopancreatography, is the interventional as well as therapeutic thing nowadays we do for palliative care of pancreatic tumors where there's obstruction of bile is there. And laparoscopy again for staging before we do a big operation. And biopsy now done through the either ERCP or biopsy can be done by the radiologist externally, as well as sometimes we can do with endoscopic ultrasound scan, we can take a biopsy from the pancreas. Now, ERCP is an endoscope which can have a side viewing camera and a side viewing port where you can insert a probe into the bile duct and the pancreatic duct, and if there's any tumor eroding into these ducts, we can take biopsies and we can take brushings and cytology and we can come to a diagnosis. And the endoscopic ultrasound scan is an ultrasound scan probe attached to the endoscope probe, and we can take pictures of the pancreas very clearly and we can see the tumor and we can put a needle and take biopsies from that lesion very precisely. Treatment, surgical resection is the only chance of cure if we get it early. We can treat, but cure is only by surgical resection. Borderline patients can be given neoadjuvant treatment and then undergo surgery. Unresectable pancreatic tumors, chemotherapy with or without surgery is the treatment. Metastatic patient, we only have palliative care. Now, when it comes to unresectable tumors, which are, say, those days, even if the tumor is invading the posterior to the portal vein or the IVC, we generally consider it is unresectable, but nowadays the new surgical techniques, they have resecting with the transverse portal vein and the superior mesenteric artery segment with the tumor and anastomosing with the graft, and those things are also happening, but still the morbidity and the mortality is very high. The surgical procedure for the pancreatic tumor, because I told you earlier, it is very closely adhered. The pancreas is closely adhered to the duodenum. If you are removing the pancreas, we have to remove the pancreas with the duodenum together. So in this man, actually, Walter Karl Edward Kausch from Belgium or France, he is the first person who described a pancreaticoduodenectomy, removing the pancreas and the duodenum together. And actually, the Alan Allfather Whipple is the person who popularized it and slightly modified this original operation. And the Whipple's name is the people who taken in than the European person's name, because Whipple was an American person. So Whipple's name goes all around the world saying the Whipple's procedure. So he dominated the name as the Whipple's procedure, and it's a pancreaticoduodenectomy. Remove the pancreas and the duodenum and reconstruct the gastrointestinal tract anatomy connecting the stomach into the gallbladder, stomach into the small intestine, gallbladder into the small intestine, the pancreas, rest of the pancreas into the small intestine. So this is classically described the common tumors which is arising from the head and neck region of the pancreas. If the tumor was invading beyond the head and neck region, they usually abandon all days, but now we can go for total pancreatic or duodenectomy. Anyway, now this is the classical diagram. So you remove the gallbladder, the pancreatic head, and the duodenum up to the first part of the jejunum, and connect the bile duct into the jejunum and rest of the pancreatic body and the tail into the jejunum and the stomach into the jejunum again. So continuing the gut region. And during this procedure, you are supposed to remove the lymph nodes around that area also. And it's a rather big operation for a small tumor. It's a very massive operation, 3 anastomosis, high morbidity and mortality. And you can do a total pancreatectomy also, and you can do a distal pancreatectomy also for a distal tumor. So distal pancreatectomy can be done. Again, the division of point is where the superior mesenteric artery and the portal vein crosses the pancreas. If it is beyond that, you go to distal pancreatectomy. If you're proximal to that, you do a Pepper's operation. If the tumor is continuing, you need to do a total pancreatectomy. The problem with the total pancreatectomy is the exocrine part of the pancreas. When you remove the pancreas, you are unable to digest protein and lipids. And because you are unable to digest protein and lipids, you need to take enzyme as tablets. That is not available in this country, very expensive. So, not happen unless you are rich enough to buy every meal with an enzymatic tablet. Palliative procedures are there when their tumor is already spread to other organs like the liver or the lymph nodes or the peritoneal cavity. We can stent the bile duct through the ERCP. You can stent the block and keep the block there. There are various types of stents. There are metallic stents, there are plastic stents, and whatever. We stent it and keep the bile flow and treat the patient. And we can revise the stent. When the stent is blocked again, we can redo a stent until patient passed away from the secondary disease. Or we can do a percutaneous stenting, that is stenting retrogradely through the liver, other way around. The Denzil will talk about those things. And other thing is palliative bypass, that is we are bypassing the tumor, leaving the tumor there. We are bypassing the tumor and connecting the bile duct and the stomach, because one day this tumor will erode into the duodenum and block the gastrointestinal tract pathway. So we have to do some creation to make sure the stomach content will also go into the jejunum. So one loop jejunum is there, other loop you connect the bile duct there and continue in the flow of the gastrointestinal tract. Those are the palliative surgical procedures for advanced pancreatic cancers. And then it will come to the end of my presentation, and thank you very much, and we will give the next speaker.